Good afternoon. Thank you for the introduction. It's a pleasure to be here. And I'm sort of going to pick up a little bit from what Dr. Sundram talked about. He talked about marketing, and I'm going to focus a little bit more on the science and update you on where we are in relation to saturated fat. So my title of my talk is slightly different, but I think it will go nicely with what Dr. Sundram just said. And what I want to do is basically tell you where we are right in my first slide. So this is a summary of what each fatty acid is believed to do in relation to fatal CHD and CHD events. And this is from a meta-analysis published in 2009 by Murray, Skeef, and Miller in New Zealand. And essentially what this tells you is that if you look at the relationship between total fat and fatal CHD, there is convincing evidence that there is no relationship. For CHD events, total fat, there is convincing evidence that there is no relationship. If we look at trans fatty acids, they're in red. So that's a negative relationship. So there's probably good evidence that increased trans fat is associated with fatal CHD. And there is convincing evidence that trans fat is associated with CHD events. If you look at a substitution of saturated fat for carbohydrate, and I will talk more about saturated fat, there's probably good evidence that there's actually no relationship for both CHD, fatal, as well as CHD events. In terms of monounsaturated fat and saturated fat, can't say anything. No information. Saturated fat replaced by polyunsaturated fat, there is convincing evidence for fatal CHD that there's a beneficial effect for both fatal CHD and CHD events. Linoleic acid, alpha-linolenic, can't say anything. And for the N3 long-chain polyunsaturated fatty acids, there's probably good evidence that there's a beneficial effect for fatal CHD and convincing evidence for beneficial effects on CHD events. So this is where we are at 2009. And you may wonder, how did we get here? Well, what I want to do in the next part of my talk, which is over the next 10 minutes or so, and then I'll discuss something else, I want to give you a quick 50-year spin on how we got here. So we've known about diet impacting plasma lipids, total cholesterol, LDL cholesterol, and low HDL, which are risk factors, and several things in the diet have an impact. Let's focus on the fat. Well, we know there are at least 17 major fats and oils in the marketplace, and they all vary in terms of their polyunsaturated, monounsaturated, and saturated fat content. So since the 1950s, we've looked at what effect these fatty acid classes have on serum cholesterol. And without looking at all these details, essentially, all the data suggested that saturated fat raised serum cholesterol and polyunsaturated fats lowered it. However, we know that serum cholesterol doesn't tell you anything about lipoprotein cholesterol. And we know you have to focus on LDL as well as HDL. Increased LDL is a risk, while increased HDL is protective. So what you have to do is to look at the ratio of LDL to HDL or total cholesterol to HDL cholesterol. You can't just look at one thing in isolation. And as Dr. Sundram mentioned, a lot of the focus is always on LDL cholesterol. So you have to look at both. And then when you look at both, you have to look at it relative to something else. And that is actually carbohydrate. So this set of data is comparing a isocaloric exchange of carbohydrate with specific fatty acids on LDL. And as you can see, saturated fat and trans fat raise LDL relative to carbohydrate, whereas monos and polys lower it. Now, almost 20 years back, we did a bunch of studies back at Brandeis University, which led to what we call the threshold hypothesis. And essentially what they said was that there are certain fatty acids which are key, and what these fatty acids do to cholesterol depends on what we call your LDL receptors. And the bottom line in this was that the problem may not be saturated fat per se. The problem may be the absence of polyunsaturated fat. So the fact that you have saturated fat in the diet may not be the problem. It's because that diet would have less polyunsaturated fat. So if you're looking at LDL levels, saturates and trans raise, but it could be that there's insufficient polyunsaturates. Now what about HDL? HDL is supposed to be protective. Well, relative to carbohydrate, all fatty acids, saturates, monounsaturates, polyunsaturates, raise HDL cholesterol. So if your endpoint is HDL, well, those fatty acids are good. If your endpoint is LDL, you have a different conclusion. So you have to look at the ratio. And when you look at the ratio, total cholesterol to HDL, monos and polys are the best. Saturates don't seem to do anything. As you can see in that first yellow bar at the bottom, they're right at 0. And trans are worse than saturates. So if you look at a combination of LDL and HDL, in terms of the total cholesterol to HDL cholesterol ratio, saturates don't really do anything. All right? So when we look at these fatty acids in these oils, you can look at them in terms of individual fatty acids, not just classes. So this figure shows what happens if you look at individual fatty acids. And we know there are several saturated fatty acids. So what happens if you compare these individual saturated fatty acids, lauric, myristic, palmitic, stearic, relative to carbohydrate? Well, if you do that and focus on LDL, lauric, myristic, palmitic raise LDL. Stearic does nothing. And so that is used to say that stearic is okay. Let's use stearic. What about HDL? Well, lauric, myristic, palmitic raise HDL. Stearic does nothing. So if HDL is your focus, then the saturates are actually okay. If you now look at the ratio of total cholesterol to HDL, lauric and stearic actually lower the ratio, whereas palmitic and myristic don't do anything. Notice in the earlier slides that Dr. Sundram showed, myristic and palmitic were considered the worst in terms of their LDL raising effect. But if you look at the total cholesterol to HDL cholesterol ratio, myristic and palmitic don't seem to be doing anything relative to carbohydrates, so you can say they're neutral. So myristic, palmitic, no effect. Stearic and lauric, beneficial. So what this is already getting at is that depending on your endpoint, you're going to come up with some different information. So where does trans fit in all this? Well, we all know what trans are, what they do, so we won't belabor the point. The only thing here is that if you partially hydrogenate a liquid oil, you will generate trans fatty acids, whereas if you fully hydrogenate it, you produce saturated fatty acids. So the key then becomes, how do these saturated fatty acids compare to trans fatty acids? And we did a series of studies in non-human primates many years ago, which Dr. Sundram also carried out in humans over here in Malaysia. And essentially we found that comparing saturates to trans were worse. Trans lowered the HDL compared to saturate. They increased the ratio of total cholesterol to HDL, and they did this by increasing a specific protein called cholesterol ester transfer protein. And it's interesting that nowadays drug companies are investigating inhibitors of cholesterol ester transfer protein for use in humans. So based on these studies, and there's several studies since, we know that trans are worse than saturates. Okay, those are effects on lipoproteins. Well, we're not really interested in lipoproteins. We want to know, what does it do to CHD? So if you go to the nurses' health data out of Boston, you have two sets of data for CHD risk and diabetes risk. And this is looking at replacing 5% of calories from carbohydrates with saturates, monounsaturates, or polyunsaturates. And you can see that when it comes to CHD, the monos and the polys lower risk. In case of diabetes, the saturates and monos do nothing. So polys are the only ones that are beneficial. And this is a 5% energy exchange. If you look at trans, this is merely 2% energy exchange. So 2% of calories from trans relative to carbohydrate increases CHD risk almost 100%, and diabetes risk almost 45–50%. So those are the worst fatty acids that are out there in the food supply. That's looking at CHD diabetes. What about long-term effects? So the Nurses' Health Study has data from 20-year follow-up. And what we have here is increasing levels of saturated fatty acid in the diet from 12 to 18% of calories. And Dr. Sundram mentioned that agencies say go to less than 10 or go to less than 7. Here we're looking at 12 to 18% of calories, and you can see there's no effect on CHD. Monounsaturates, 12 to 18% of calories. There's a gradual reduction in CHD risk, but it's not significant. In the case of polyunsaturates, going from 4 to 7% of calories, there is a significant reduction in CHD. And in contrast, trans fatty acids going from a mere 1.6 to 2.8% of calories, there's a 40% increase in CHD risk. So the lipoprotein data is matched by the CHD data. So polys are beneficial and trans are the worst, just like what the lipoprotein data suggested. And in terms of saturated fatty acids, well, they don't seem to be doing anything at all. So is there additional evidence that this role of saturates is not what we thought? Well, there's several other studies. Here's a study looking at the changes in the size of LDL. Basically, you can have small LDLs and large LDLs. And if you have small LDLs, that increases risk, whereas large LDL doesn't increase risk. And essentially what this data shows is that if you go from a diet with 6% of calories from saturates to 18% of calories, you have an increase in large LDL and a decrease in small LDL. So that's actually good. As heart disease progresses, what happens? Your coronary arteries get smaller and smaller. They narrow. So in this study, you go from 3.5% of calories from saturated fatty acid all the way to 16% of calories. And what you're doing is you're slowing down the progression. You're slowing down the narrowing of those coronary arteries. So that's good. And this is by increasing saturates. We look at lipoprotein A, which is another lipoprotein. It's a sort of cross between LDL and HDL. And high levels of Lp(a) are supposed to increase CHD risk. And here we see data which clearly shows in humans that saturated fats produce the lowest levels of Lp(a). So that's good. So on one hand, you're saying saturates raise LDL, but clearly LDL is not the whole story. In the last 3 years, there have been 2 phenomenal studies that have come out which have really put a damper on all this, and our thinking has completely changed. So Marian Jacobsen in Denmark did a meta-analysis looking at 11 studies with some 350,000 subjects. And everybody keeps saying reduce saturates, reduce saturates. So her group wanted to see what would happen if you decrease saturates. You have to replace them with something. You can't just take saturated fat out of the diet. You invariably end up replacing it with something else. And what her group found was that these coronary events decreased when you replace saturates with polyunsaturates. If you replace saturated fatty acids in the diet with monounsaturates, think olive oil, there's no benefit. If you replace with carbohydrates, there is no benefit. And her group has a follow-up study which showed that if you replace saturated fat with high glycemic carbohydrates, you actually increase risk. So you're taking out saturated fat from the diet and putting it carbohydrates, and your risk is actually going up. So you have to be careful that if you do take saturated fat out, what do you replace it with? Then came a study from California by Ron Krause's group. Again, a 5 to 23-year follow-up, looking at some 350,000 subjects, and they looked for the effects on CHD or stroke. And when it came to saturated fats per se, no effect on CHD, no effect on stroke, and no effect on cardiovascular disease. So all this data is saying is that saturated fat per se may not be the problem that we've been telling people for 40 years. From this, Darius Morizafarian in Harvard published a paper in 2010 in which they looked at diabetes in populations consuming very low and very high levels of saturated fat. And as you can see, there's absolutely no effect. So altering the amount of saturated fat, low to high quintiles, no effect on diabetes. And then they did another analysis where they looked at specific replacement of saturated fat, either with polyunsaturated, with carbohydrate, or with monounsaturated, using different types of analysis. So if you base things on total cholesterol to HDL, if you replace saturated fat with polyunsaturated, you get a reduction. If you look at meta-analysis of clinical trials, you get a reduction. And if you look at observational studies, you get a reduction. But if you look at saturated fat replaced with carbohydrates, nothing happens. And even more interesting, you look at saturated fat replaced by monounsaturates, yes, you see a reduction in lipoproteins, but in terms of randomized control trials, there aren't any. And if you looked at observational cohorts, they don't show anything. If anything, they show an increase in risk. So the conclusion again is saturated fats per se may not be doing anything. And then in this paper from Misha and Mozaffarian, they published this figure, which I would like you to think about. So if you were to sum up all the evidence for fatty acids and cardiovascular disease, saturated fat is sort of right in there, doing nothing, sort of sitting there neutral, benign. What provides benefit? Fish oil fatty acids, plant-based N3 PUFAs, plant-based N6 PUFAs, and maybe monounsaturates. What provides harm? Refined carbohydrates and trans fat. So all the data is consistent that trans fat is the problem, and specifically trans fat from industrial sources. So how can we replace trans? Well, you can certainly use animal fats, but there's a limit to how many animal fats are available on the planet to satisfy all this. We can have interesterification, genetically engineered crops, and of course, there is palm oil. So let's quickly go through, and this is the last part of my talk. So if you're replacing trans, which Dr. Sundaram also pointed out is the major thing to do from a public health perspective, here are those fatty acids again. Look at soybean oil. Right here, if you fully hydrogenate it, you generate stearic acid. Stearic acid, they will argue that LDL, it doesn't raise LDL. It doesn't do anything to HDL, lowers the ratio. But what does it do to CHD? Well, we don't know. So yes, you can certainly use a high stearic soybean oil, which you then intersterify with the fat of interest. Genetically modified oils, Dr. Sundaram touched on those. So here is sunflower, soybean, and canola. The figures in yellow are the native fatty acid compositions. And then, of course, you can generate different genetically engineered oils with an altered fatty acid composition, which are there to provide stability. But then as that Monsanto study in the rats shows, feeding GMO crops to animals may not produce the most desirable outcomes. So then, of course, you can go straight with palm oil. And for almost a decade, there was an expert panel in the US which basically said that palm oil was a reasonable replacement for trans fats. Now, of course, everybody knows these figures because we've heard them ad nauseum today as to why palm oil is the ideal choice. So given that palm oil is the ideal choice, what other benefits do we have from palm oil? Well, we know we've got very high vitamin A. And there's convincing human data, and there are many, many studies, which I don't have time to show, where they've used red palm oil to fight vitamin A deficiency. And these are studies from many parts of the world. And using this red palm oil, or caroteno, as it's available, you can incorporate it into diets in many different ways. So in India, they've made traditional sweets with red palm oil. You can give, in South Africa, as the studies were done, school children fed biscuits with red palm oil. You can give red palm oil daily, orally. In Tanzania, they've done studies where they've cooked green leafy vegetables in red palm oil, and that produces benefits. So there's many, many ways of incorporating vitamin A from red palm oil into human diets, and they are effective. Then, of course, there's the vitamin E content about the tocotrienols, and palm oil is the richest natural source. Lots of studies on tocotrienols, and probably the most advanced ones are the ones on neurodegeneration, and Pramod has funded some clinical studies to look at the possibility that tocotrienol supplementation delays the onset of strokes. So there's many, many attributes for palm oil that can be used. Now, if we were to put this in the diet, there are some practical questions. So one question is, what do these diets made with palm oil do to lipids? Well, there's several studies comparing palm, olive, and canola, and Dr. Sundaram's done some of those. So if you look at the ratio of total cholesterol to HDL, all of these studies are showing similar effects, whether you're comparing palmoline with olive oil or palmoline with canola. So as far as the lipids are concerned, palmoline and olive and palmoline and canola are similar. If you're trying to incorporate palmoline into a diet and you want to follow current dietary guidelines, so if you're following a guideline which says 30% of calories from fat and less than 10% of calories from saturated fat, that means 70% of your fat can come from palmoline. If you're following a diet with 30% of calories from fat and you want to have less than 7% of calories from saturates, that's 50% of your fat. Half of your fat can be from palmoline. So practically, you can put in anything from 50 to 70% of the total fat in a human diet from palmoline, and it will satisfy current dietary guidelines. So how would that affect CHD risk vis-a-vis trans fatty acids? Well, if you just base it on plasma lipid changes, replacing 2% of calories from trans with saturated fatty acids would decrease risk by 4%. Now, if you factor in other parameters besides just the plasma lipids, we're talking about a 17% reduction in CHD risk just by replacing trans fatty acids with palmoline. So what's the practical aspect of this? These are my last two slides. Again, this is data from Mozaffarian. They did a mathematical modeling. And what they said is that in real life, you don't replace trans fatty acids with saturates. What you replace is partially hydrogenated vegetable oil with saturated fatty acids. So let's just look at this bottom one, which is the most exaggerated data. So if you take partially hydrogenated vegetable oil with 45% trans fatty acid and replace it with palm oil, butter, lard, cottonseed, high oleic safflower, soybean, and canola, and look not just at the total cholesterol to HDL cholesterol ratio, you look at lipoprotein little a as well, and the ratio of apoproteins as well as inflammatory marker C-reactive protein, they're all as good. So from a practical aspect, if you take out trans and replace it with anything, you will get a reduction in CHD risk. You will get benefit. And it doesn't really matter which one it is. What will matter is the functional aspects that you want to attain in your desired fat. There's also been analysis done by Barrage et al. And Menti looking at risk assessment. And if you actually look at risk assessment from a population basis, this is in the US, what would you invest your money on in terms of a public health message? If you do that risk analysis, focusing on saturated fat actually gets you nowhere. Focusing on dietary cholesterol actually gets you nowhere. You're far better off focusing on getting rid of smoking and getting rid of trans fat. So, if we summarize all this, fat quality is more important than fat quantity. We have consensus on trans and the N3 PUFAs. And if you replace trans with saturates, CHD risk improves. And saturated fatty acids per se, we basically need to have a rethink because we've had these 4 big studies in the last 3 years encompassing data from some 1 million subjects. And so saturated fatty acids per se are not the issue. So that way, palm oil then is there to serve a multitude of nutritional needs. Thank you very much.